Welcome to the Forum, live streamed worldwide from the Leadership Studio at the Harvard T.H. Chan School of Public Health. I'm Dean Michelle Williams. The Forum is a collaboration between the Harvard Chan School and independent news media. Each program features a panel of experts addressing some of today's most pressing public health issues. The Forum is one way the school advances the frontiers of public health and makes scientific insights accessible to policymakers and the public. I hope you find this program engaging and informative. Thank you for joining us.
My name is Sanger-Katz. I'm a correspondent at the New York Times, and I'm your moderator today. I want to introduce our panel. To my immediate right is Bob Blendon, who's a professor of health policy and political analysis at the Harvard T.H. Chan School of Public Health and the Harvard Kennedy School. Next is Eric Schneider, who's the senior vice president for policy and research at the Commonwealth Fund. Bob Master, who's the founder and former president and chief executive officer of the Commonwealth Care Alliance. And joining us remotely is Toyin Ajayi, who is the chief health officer and co-founder of City Block, and I know also a Boston alum. So this event is being presented in collaboration with the Commonwealth Fund, and we are streaming live on the Forum, on Facebook, and on YouTube. We are going to have a brief Q&A at the end, and so those of you in the audience prepare good questions, but those of you who are watching remotely can also email your questions to theforum@hsph.harvard.edu, and you can also participate in a live chat that's happening on the Forum's website right now. So to come to our topic today, if we really want to understand how the healthcare system is working, I think it makes a lot of sense to see how it's working for the people who really need it. And I was surprised when we began this project to learn that there has never been a major survey of the seriously ill people who use the healthcare system the most. So this year, with the Commonwealth Fund and the Harvard School of Public Health, we surveyed nearly 1,495 people who had real health problems, multiple hospitalizations and doctor's visits, and often many other needs besides. And some of what we found was pretty disappointing. Patients said they were receiving care that was confusing, conflicting, dispiriting, and included medical errors. They also reported substantial financial distress despite health insurance coverage that was supposed to protect them. So we're going to take a closer look at the poll results today. We'll also talk about some of the less obvious costs of serious illness, costs that don't necessarily appear on medical bills but still make it hard for people. And we want to talk about some possible solutions so it won't all be doom and gloom, including programs that our panelists are working on to try to address these issues. So first, let's watch a clip from the U.S. Department of Health and Human Services that brings home the financial impact of serious illness.
I am Richard Knight of New Carrollton, Maryland. Life before I was diagnosed was very good. I was running my own business. I was president of a Boys and Girls Club. 1996, I went to get some life insurance. I had the blood work, urine test, and I was rejected. And as it turned out, I had impending kidney failure. My kidneys continued to deteriorate until 2004, when they shut down completely. I went to the emergency room. I began dialysis. I was 51, 2006, when I had my transplant. I had an amazing recovery. I was taking immunity suppressant medication that was fairly expensive. I am looking at a couple of $100 a month copay, even with Medicare. And first, I have to pay for the deductible every year. I probably won't retire, and one of the reasons is because of the cost of the medications that I will constantly have to pay for. The fact that the government is looking at the cost of drugs is a plus. I'm very encouraged by that.
American Patients First, hhs.gov/drug pricing. Produced by the U.S. Department of Health and Human Services at taxpayer expense.
So we just saw the story of this one patient who was facing a lot of financial obstacles, even though he got this amazing organ transplant that changed his life. Bob, I know we had a lot of questions and a lot of answers in the poll about people facing these kinds of financial stresses. Can you talk a little bit about what the results were?
So we'll do this quickly, but the biggest finding is for 50 years in this country, we've been debating how to help people who aren't insured. And the assumption is once you get them the card, they are protected for the rest of their lives. And we're going to take you in a world where seriously ill people with insurance, including Medicare, are facing staggering bills. It has nothing to do with the dialogue we've been having for 50 years. You cross the Rubicon, now you're safe. So let's just do this very quickly. First is buried in every story about, first slide, healthcare in America is 1 in 6 people who are extraordinarily ill over a 3-year period. And so the people in our sample, 100% of them were hospitalized at least twice, said they had a serious illness. A quarter of them were hospitalized 5 times in 3 years. They were mostly seeing 5 doctors or more, so you talk about information coordination. They are taking 5 or more prescription drugs. And just to show, we'll show in a minute, insured America, 1 in 10 had $50,000 a year of prescription medication bills. And these are people who in fact say they're seriously ill, and they have one of the major killers. So these are not routine patients at all. Let's just take a look at what happens. Next slide. So the gray bars are all 91% of people, good news, had a health insurance policy. Wow, I can feel good about that. Here it is. I have a health insurance policy. 53% of people with a health insurance policy had serious medical bills. They had problems paying it. And so a third were hospital, but I'm insured. A third, prescription drugs, emergency rooms. These are not stories about the uninsured. These are stories about people who have an insurance card. All through our poll, each section we ask you what worries you most. Mostly, I don't know why I can pay for this. Suddenly they're being told that this policy that they're lying in a bed with is not going to do that. Next slide, please. Take quickly. So if you just look at the gray bars, I have insurance. My family feels reassured. 36% of the insured people used up all their savings. As a result of having this, they had insurance. 21% couldn't pay for basic necessities, having insurance, and lost the job. And we'll get back to this in a minute. Most people who work in America have short-term sick benefits. Guess what? If I'm not sick over these periods of time, my benefits run out. And my job sends me a loving note about you may not be able to continue for this. So we have that. And the last slide, very quickly. So all of us have stories and may have played that role where a friend or family member, when you go home from the hospital, takes care of you for a while. But these are people who have long whiles. So this is the financial experience of the person who cared for you at home. Not you, them. So 1 in 4 of those people had significant financial problems because they had to cut back on the rest of their lives. And 21% of them just said, I had to care for someone at home. I have a lower income as a result of that. So just the 2 takeaways from here. Now that we're moving away from the uninsured debate, there's a serious problem if you're seriously ill. About whether or not your insurance will cover you. Secondly, sick days, which at Harvard may be terrific for as long as you want to be out, are not that good for other people. And if you have a long-term illness, you start running out of your sick days and you have an inability of keeping your financial viability. Eric?
Great. Thank you. And I'll take the next slide.
Not exactly great, but it's...
So Eric, tell us aside from finances, how's the care that this population is getting?
Yeah, so I want to turn to that now, but first I want to say it's great to be back here. I've taught at the school and done research here since 1997 and joined the Commonwealth Fund 4 years ago. It's exciting to be working with Bob again and to see so many colleagues and friends in the audience. What I want to turn to next on the next slide is this issue that really dates back to my arrival at the Harvard School of Public Health, which was the Institute of Medicine began to publish a series of 3 reports. To Err is Human, about safety, the Crossing the Quality Chasm, about the quality of care, and a report on disparities, racial and ethnic disparities in care. And that's 20 years ago now. And what our survey has revealed is that for this population, we've actually made remarkably little progress in tackling some of the problems that were outlined in those reports. The other thing I wanted to mention here is that about 56% of this group has emotional problems, anxiety, or depression attributable to their illness. And people who may not have started out that way often fall into a sort of vicious circle in that front, as well as the financial. So the next, this slide shows that about 61% of people in this population experience one or more problems that we identified that actually were identified by the original Institute of Medicine report as problems. Poor care coordination, a lack of clarity about services, and a lack of responsiveness of staff to the needs of those people. And you can see that those range, it's 1 in 5 or 1 in 4 who are experiencing each of those or reporting each of those issues. The other issue that comes up on this slide is patient safety. 23% of the people in this survey are reporting that they experienced serious medical errors. That's a high rate, not entirely unexpected because it's a complex population, but we have to probably do better on that. So I'll take the next slide. I'm just going to sort of pivot to the solution side of this and give a little frame in terms of our conclusions about what's needed here. And this is really based on the needs that patients experienced and reported. Up until the last 20 years, many people have focused more on the delivery system side, and as I just said, the delivery system side is not doing what it needs to do. But this survey was an attempt to actually report on the user needs, the experience of these vulnerable populations. So the first area of strategies that we identified is the issue of building behavioral health capacity to manage behavioral health needs of this really challenged population. The second is the issue of assessing and then addressing the social needs that people have: housing, transportation, nutritional needs. Those are unmet in our survey for many people. The third is to make coordination of care a priority. People talk about care coordination. There have been a lot of federal effort to try to bring about care coordination in the system, but there really is still a high level of reporting that the care is not coordinated, and that primary care in particular is not able to solve this problem yet for most people. And then the fourth is the issue of making care more affordable to avoid the sort of vicious cycle that Bob pointed out. So with that, I'm going to turn it over to Bob Master.
Oh, thank you. So what I think I can talk about is what about all of these issues in people with additional challenges, low income challenges, what we now call social determinants of health challenges, and people who in fact probably have the best insurance you can have when you put Medicare and Medicaid together. You don't have the financial issues, but you have a care delivery system that is hopelessly in need of redesign to more effectively provide care. So what are the clinical characteristics of this population? And it's heterogeneous, but clearly, as we talked about, you have one or more significant chronic illnesses that have very low thresholds to hospitalization. And we'll come back to the hospital part because that's a part of the downward spiral. You have very high prevalence of people that have long-term service and support needs that are not fully independent and may be fully dependent in everything along the spectrum, and whether that's a frail elder or whether that's a younger person or even a child or adolescent with significant disabilities, that adds to it. As Eric said, behavioral health prevalence is extraordinarily high, and the integration is just the beginning. What is really needed, and if we're going to prevent that downward spiral of recurrent hospitalizations, 95% through the emergency room because of the low thresholds, and each of the spiral leads to more transitions. It's in the transitions where you have the problems and the errors. You're going to need an absolute redesign of what is done in addition to the need for coordination. It isn't coordinating all the pieces here. We have to change what is happening in those pieces, and we can talk about that later.
Toy, and I know you guys at City Block are treating this population who are facing both these medical and some of these financial challenges. Can you just talk to us a little bit about how it looks close to the ground?
Sure. And first, just to commend you all, thank you so much for this research. It's just so important to start to quantify how significant these financial barriers can be for people with serious illness. It gives voice and data to what we see in our clinical practice. And I think the key things to note in real life for the population that we're serving is that this manifests both in the financial burden that you articulated, but also in a whole host of continually hidden costs to the patient and to the family that are essentially invisible to the healthcare system. And so when I see my patients in practice, not only do we ask about and do we see the costs, the financial costs of care in the form of particularly pharmaceutical costs, but also have to pay attention to the opportunity costs. And so when you're talking about a population of folks like the folks who we serve, who have insurance, by and large, as Bob described, this is probably the best insurance you can get. It's Medicaid, or it's Medicare, or it's both. These are folks, though, for whom their time is one of their most valuable assets. And what we don't capture yet is the financial, the opportunity costs of being seriously ill. So you're asking people to take time off work. If they're working, that's cash out of their pockets. If they're an hourly wage worker, it's pretty significant. We're asking people to pay for transportation to get to the appointment. We're asking people to pay for childcare while they're sick or while they're accessing additional services. That recurrent cycle continues to exacerbate the costs in that household. Additionally, as some folks have already started to describe, the barriers to addressing all of the other needs a person has in their home and in their life in order to access effective medical care can be huge. If you're trying to make a decision between whether you pay $400 for a copay for your insulin, or if you're behind on all of your other bills, your rent, your utility bills, it's understandable why people make rational choices not to access healthcare. And yet to the providers in the healthcare system, we know that often asking people about financial burdens in their lives is taboo. We feel like our job is to provide the best medical care and the best medical recommendations, regardless of our ability to pay and regardless of people's incomes. So recognizing that your financial status plays a role in health and well-being is something that doctors typically aren't trained to do, and it's something that the healthcare system is not oriented to do. We find that in our population, not asking those questions should be tantamount to medical malpractice, because if you're asking someone to do something that means that they don't feed their children or clothe their children, or asking them to make choices and take time out of their day in ways that disadvantage them in other parts of their lives, we are doing them harm, and we need to be really cognizant of that as well.
So in a moment, I want to talk more about solutions to try to improve some of these problems that we've identified. But first, I want to another video clip about a program that is trying to do that called the Guided Care Program. And this clip comes from the Commonwealth Fund.
When we have a doctor's appointment, she'll go there with us.
So how are you guys doing?
And she'll sit there and listen to what the doctor has to say.
It's been wonderful having her. It gives me a sense of security.
I think the biggest challenges they face medically is just trying to be as healthy as they can within their limiting conditions. As a guided care nurse, what I try to do is give them ways to feel more confident and to have them do their own health care or their own med setup, but then double check to give them that comfort that they know they're doing it right. Part of my role is seeing them in their homes, going to office visits with them, doing telephone calls in between.
Yeah, hi, this is Patty. I'm just calling to see how your medication is working.
We found that guided care really helps in those transitional areas because that tends to be when patients will fall through the cracks. If the patient is hospitalized, I see them at the hospital. If they're discharged to the nursing home, I go there. My biggest role is to guide them through wherever they are, be it at home, at the office, at the hospital, and make sure that their care is transitioned and there's no errors made.
So Eric, I'm curious, you obviously know the most about this particular program, and I'm wondering whether you think this program or other programs like it can start to make a dent in some of the problems that we've just been talking about.
Yeah, I would love to get Bob and Toyin's opinion on this too, but it really does illustrate the need to move care into the home-based setting, into the community as much as possible. We really haven't pushed the envelope in terms of that, and I think I just want to reiterate Bob's point that, this Bob, that
now we're surrounded.
that it's not enough to coordinate the existing building blocks of the system. We really actually need to innovate and redesign the care to deliver it in the home, to address a lot of the other issues that one can see. I've done home visits. One can see these issues that will never come up in a clinic setting. And so I think that's really important.
I can start. By the way, I think after working with Toyin for over 6 years, we can complete each other's sentences, and maybe we should do this as a team without question. But if we just look at those building blocks, first of all, what are the redesign elements? And I really do want to start with the extraordinary work that was really done as part of the ACA to really try to scale systems of care and change that really really was neglected for decades, ever since the onset of Medicare and Medicaid, and that was the beginning of global payments, where a clinical organization with the appropriate risk adjustment could have complete responsibility over all of the benefits and services of medical care, hospital care, pharmacy, and long-term care that you could bring to a person, and that allows you to reimagine care. So fee-for-service, piecemeal care where a physician in an office is seeing people in 15-minute visits don't work. And the next thing that is really required in that is to reimagine primary care. And that would be not just a doctor in an office, and not just 3 to 4% of the total medical spend going to primary care, but in fact an interdisciplinary team that may look different for different populations. And that would be the doctor, the nurse practitioner for people with physical disabilities, integrated physical therapy and occupational therapy and durable medical equipment for the integrated behavioral health, to reiterate the importance of that in practices. And you're now then talking about 10 to 12% of the pie that has to go to primary care. And that is that, and until we resource that correctly, and until we move to global payment arrangements, you're not going to be able to do that. You then have to build in what we call elasticity into the system in primary care. When a doctor like Toyin and I go to work in the morning, most physicians are booked from 8 in the morning until who knows when in the evening. And yet if you have people with low thresholds to problems that are going to occur, how do they receive that care? In the United States today, it's the ambulance in the emergency room. So thinking about elasticity, if you have a frail elder at home or a person with disabilities, you've got to get that assessment and you've got to move it into the home. In fact, for people with physical disabilities who rely on the publicly funded rides, they can't get to a doctor's office immediately because you got to have a 24 to 48 hour appointment window to do that. So it's now primary care as a service and not a building, and seeing people as needed and not by appointment. And then comes the second and third stage. How do we then move into what we call the primary care white space, which is what happens after hours when somebody is sick and a physician takes that call at midnight and you can't figure out whether this can take 2 aspirins and we'll see you tomorrow, or you're really sick, we got to get you in now. Most of it falls in the middle where you don't know what's happening, and by default this frail elder or a person with risk for hospitalizations goes to the emergency room. What do you do there in terms of system change? And there is some interesting work with advanced life support clinicians that can do this kind of response as part of a primary care team. And the last, and I'll stop here, is the redesign of how you care for people in the hospital. In one sentence, you're moving primary care and continuity into the hospital, and so when a person needs it, they've got their teams there, and I'll stop there.
So Toyin, I see a lot of nodding.
So much nodding.
I'm curious, as you think about these opportunities for improving coordination for this population that's really sick, people who have a lot of illnesses, who've been hospitalized a lot, who have a lot of medical needs, are the strategies do they carry over to like those of us who are normally healthy but maybe have a crisis every once in a while, or does it feel like a unique problem that needs a unique set of situations? Like, I'm just wondering, how much is this like a good metaphor? Like, if we figure out how to solve these people, then we're going to translate it over here. How much of it is like, okay, let's just do one thing here and one thing there?
I think it's a really great question. So, the way that we have typically used innovation in healthcare in particular has been that we've solved for the healthy. If you think about the typical primary care model, for example, it works great if you're in your 20s and you don't have a lot of medical needs and you can afford to take time off work to go see a primary care doctor, and you can wait and you can come back and pay the copay and get your once-a-year physical. It works fine. It's not perfect. It could be better, but it works fine. And the innovation in primary care largely has been to try to make that interaction more seamless for people who are relatively healthy and have resources. That doesn't work. It's not going to trickle down to people who are sick. It's not going to trickle down to people with complex needs for all of the reasons that Bob described when you talk about the 24/7 nature of their need for access to high-quality health care. That said, however, any single one of us who is healthy today is, as we know, a unfortunate accident, a catastrophe, an undiagnosed cancer away from being sick. And the data from this study shows that if that happens, no matter where you start, if you're insured or not, the risk that pushes you into poverty is so great. So suddenly we have a frame in which the safety net system that we're building actually may serve any one of us, any person in this country who is going to age and be sick over time, which as the population ages and as we start to prevent more and more diseases later into our adulthood is going to be most of us, right? As we get into our 60s and 70s, the likelihood that we are living with chronic conditions is incredibly high. And the likelihood that one of those makes us have to seek hospital care and expensive drug treatments that push us into poverty is also quite high. But when we build solutions, we have to build intentionally for that population. And the lessons will trickle up, if you will, to people who are less sick, who need less of those services. They may require fewer of the tools in the toolkit in a much less frequent fashion, but we need to have them there because it could be any one of us. And so when we think about really focusing innovation, putting together the best teams we can around technology, around operational design, logistics, 24/7 access to care, it is in service of this use case. Our hypothesis, though, is that as we start to push those tools out, they will become in service of folks who are in less need today, but over time may become high risk.
I just wanted to make sure that we circled back to Bob's slides about some of the financial stresses that people face, because those really did stick out to me, and I feel like connect to a growing body of research that shows that not only are we seeing more people with insurance that has high cost sharing that exposes them to a lot of out-of-pocket costs, even if they are insured, but also growing evidence that being sick has other financial consequences for people because, if you can't work, even if you don't lose your job, if you have to take time off, you have to cut back on your hours, if you have disability that makes it hard to do the same kind of work, that losing income can be an additional financial challenge associated with being sick. And so I'm just wondering, how should we think about this group of problems? Like, is health insurance good enough? What can we do to make it better? Do we need other kinds of wraparound insurance for people so that when they get sick, they don't get pushed into poverty, as Toyin described?
So I'm going to surprise you. I'm not going to say it's all very complex. First, all you have to do is turn on the TV and look. We're now in the Medicare enrollment choice. And it says, pick the Medicare wraparound that you need. The first thing out of this survey is very few people knew 3 years ahead that they would have 5 hospitalizations, $50,000 of drug bills, 5 doctors. They had no idea. And we're telling them to choose a plan. Now, how can I be insured and have $50,000 of prescription drugs? That's easy. I bought a drug benefit, except somebody gave me a drug for cancer or something, and that little drug benefit won't do that. And so we're having a debate for the under 65. Let's choose the plan you need. There's no reason that you should have requirements. Same thing happened. A young adult choosing has no idea they're going to be hit by a car or have a heart attack. And so they don't know. So what do we need simply is not what appears on television. Get yourself a counselor to read the 47 pages of the Medicare alternatives. No, there has to be a federal or state agency that certifies, very simply, little star, if you buy this plan, it will cover you for your catastrophic illnesses. You don't have to read the other 47 pages. And it probably is going to have to extend coverage that isn't there. You should not require people to have to figure out, will my cancer be a type 1? And that'll be covered fully by the policy, but a type 2 isn't fully. You're not going to know that. So a nice little star says, don't worry, when the ambulance comes and you're there, you have a policy that will cover it. We have no certification. Likewise, we need a catastrophic something for work-related days off benefits. At some point, it kicks back in. And if you really are caring for somebody that needs a lot of care, or your job has some protection that after 14 days of sick days, they don't fire you. And it has to be a requirement where it kicks in way down. But those two things, an easy certification. But please, the people we surveyed could not read a 37-page choice document. And that ad which says we'll get you a Reaper and we'll work your way through that's exactly what is not needed. What's needed is a simple certification that says if this happens to you, and by the way, if we told you we were giving a drug benefit, the company can't say I'm not going to pay for this drug. It's just not fair to people. They have no way of knowing that they're going to get that prescription. So this is simple, but I'm a tenured professor.
It sounds like an expensive system what you're describing.
That's why he does costs and I do protection.
Do any of you other guys have thoughts about this cost problem?
I just very briefly have to respond. Now that I am a Medicare beneficiary myself and having gone through this, and I think I know more about this world than most people, having lived it for decades. I won't say how many, and this policy decade, and it was opaque, absolutely opaque in saying which drug plan do you pick, which wraparound Medigap do you pick, and I'm saying, oh my God, if it's opaque for me, how is it for people that are not in healthcare in this world?
I would say it's like the most common email that I get from colleagues is like, or friends, can you help me select between these options?
If I could just add one thing, I mean, this is the quintessential kind of market failure, right? Like there is such a lack of information available to people in making these choices. And I think what, just adds insult to injury is that this data is available and actually it's being used for, I would argue, not for good by other agents within the healthcare system. So you think that, health insurance plans can tell by your purchasing patterns, your demographics, and where you live, the likelihood of you becoming seriously ill in the next 5 years. And they do use this to try to figure out where they should market their plans, right? They want to get the healthiest people on their Medicare Advantage plans. Large retail stores know exactly when you're likely to have a need for X or Y product, and that's when miraculously the ad shows up on your iPhone or the flyer comes through your mailbox. We have the data to help people better understand what their risks are and what the likelihood that they're going to need catastrophic coverage and how they should be prioritizing their resources. So even just giving more transparency to that information, some guiding, some coaching, and then I love the idea of certifying plans that when you're buying something, you know what you can expect from it. It's such a fundamental thing I think we can do to help people, in addition to all of the work that we need to do to put pressure on the broader system to really ask what coverage means and what our commitment to ensuring that when we say people have insurance, that they really have insurance. It feels like there's almost a nomenclature gap here as well, because we're not saying quite the same thing when we say you have coverage and then we find out that actually your out-of-pocket costs are through the roof and you had no idea.
Yeah, just to put a number on this, the Commonwealth Fund survey, which tracks the adequacy of health insurance, the underinsured rate, people who really are facing unmanageable costs in any given year, has gone up to nearly half the general population, let alone this very vulnerable population. The other thing I just wanted to say is that we've been now 20 years into a cycle of consumer information and transparency that would somehow allow people to make good choices and create the incentives for organizations. And many people are starting to conclude that that's not a successful strategy, or at least not sufficient to solve some of these problems. So what we have now is people with insurance facing high deductibles, facing ruinous costs, and that's colliding with a system that has consolidated where costs are escalating dramatically, where the prices are really out of control because there's no counter-negotiating power. And from a policy level, that's a really important issue. If people can work on that, we would be delighted to talk to you after this.
So we're just about at the time for questions. So I'm going to start with a question that we received through our email system, but all of you guys, you're next, so get ready. This is a question that gets back to the caregiver issue, which I was hoping we were going to touch on. What can we do in terms of policy change to help caregivers like family and friends manage the stress and responsibility of helping ill patients once they get home? So many patients need support when they return from the hospital, and workplace policies in particular make it difficult for family and others to provide coverage. So there was a lot of information in the survey about caregivers, about the financial stresses that we saw in Bob's slide, but also just like how hard it is, emotionally for them, and how much work it is to care for their ill relatives. And so I'm curious what thoughts you guys have about that, about what we could do better for those people.
I'll just say, I meant to say this earlier, that the Commonwealth Fund has teamed with 5 other foundations, the Robert Wood Johnson Foundation, the Peterson Foundation, the SCAN Foundation, Hartford Foundation, and Milbank Foundation, to create a digital resource, which you saw a clip from, called the Better Care Playbook. And the purpose of that is to really feature evidence-based interventions that could be helpful to people with complex needs. And caregiver support comes up over and over again, and we saw that in the clip there.
Again, some lessons from the Medicaid world. Medicaid really was our nation's first long-term care and disability insurer for support care, and maybe it's the only comprehensive one. One of the most important supports was personal care assistance, self-directed personal care assistance, which was a unique Medicaid benefit that grew up over decades. And at least in the more recent iterations that Toyin and I have been involved in, was the opportunity to essentially have family members, whether it's a spouse, whether it's a daughter, son, granddaughter, grandson, nephew, neighbor, friend, be that caregiver and reimbursed. And you say, well, how can you do that? Well, in some ways, how can you not do that? Because the cost of having some reasonable reimbursement for that kind of support is the alternative to a skilled nursing facility in many cases. Or worse, for many frail elders, more of a long-term nursing facility at several $100s a day. So are there lessons from the Medicaid world? And historically, Medicaid was always viewed as the marginalized twin to Medicare, but in fact has been this engine of policy innovation, and that's a good example. And is that applicable to to the more broad and general population?
So what would the idea be, that like your health insurance benefit should include some stipend for someone who takes care of you if you have a really serious problem?
And you don't have a Medicaid card.
Right.
Yeah. Possibly, and it may be very cost effective in the investment in that, and absolutely.
That's really interesting. Right. Any other thoughts?
The other thing I would add is, and it's not quite responsive to the question because it's not as much a policy lever as it is a care model lever, is thinking about social care. And so we at City Block really focus on kind of going beyond screening and referral for social determinants, but thinking about social components of care as a holistic piece of the puzzle. And that means asking both, who do you depend on for supports, physical, practical, tangible supports, as well as emotional supports, and also who depends on you, and recognizing that every person is part of a complex ecosystem of relationships that at sometimes make them dependent on another and other times allow them to be the support person for others. If we ask those questions as a matter of routine in all of our healthcare interactions everywhere in the system, then it necessarily sort of behooves us to start to act on those. And so when you think about people going home from the hospital, if it was the business of the healthcare system to know that your daughter is the person who really supports you in getting dressed every morning, and that she's just taken a new job out of town or something, then we're able to start to think about what it looks like for your discharge home and what are the supports we would need to put in place. Versus the converse, recognizing that if we have patients, individuals who are also carers, because we can be both, we can be seriously ill, dependent on others, and also carers for others, the impact on the whole ecosystem around you can be profound. And so what we're finding in particular when we think about kind of cost is that interventions on social care are cheaper in general and accrue returns across a larger number of people than a healthcare intervention where you treat a patient and that patient derives benefit. If you're thinking about, for example, food insecure individuals, if I had a senior who didn't have enough food, was dependent on their daughter or granddaughter to help make sure they ate every day, and we worked with them to make them less dependent on that family member, we've actually unlocked capabilities across the whole family. And that's really a powerful set of interventions. And so thinking about social care, both as understanding of what people's social abilities and needs are, and then addressing those just as you would any other part of their healthcare needs, can be a really powerful way to start to address the burden on caregivers.
Do we have any audience questions? Yes, right here, if we can get a microphone.
Good afternoon. Thank you so much for what you guys have shared so far. So I'm Bryan Buckley, a second-year DRPH student. And so you've talked a little bit about the aspect of social care and how care is really expanding outside of the four walls of the hospital. I'm interested in the role that telehealth and home-based care, and where do you see it both on the opportunity cost side of things, but also reducing financial costs and different reimbursements that we can go with that.
Bob, you have to start.
I was going to say the same thing about you, Toy.
I learned everything that I know about this at his feet, so I could never.
One of the, there is no question. I think that if you enable a clinician with telehealth ability to actually access the home, that's a step up. The concern I have is where that is. The love affair with technology is a replacement for the care system. I think it's an enabler and an enhancement to a care system, but it really still starts with that home-based personal capacity. How do we move primary care into the home? How do we have a response to new problems? How do we have the allocate the right amount of long-term services and support services that are needed? And then telehealth clearly, I think, can enhance that. But in and of itself, without a system redesign, I have problems. I don't know. What do you think, Toyin?
I agree. I mean, of course, I agree 100%. I mean, I think, going back to the foundational principles of what we're trying to solve for, when we have people with serious illness, with multiple competing concerns, who also either in addition to and before they became seriously ill or as a consequence of their serious illness are also struggling with social needs, that home visit and that home-based care is just catalytic. It's in two ways. One, I think the questioner asked about kind of the opportunity cost, and that's huge. So saving people from, the whole cycle of getting into a clinic multiple times, sometimes even multiple times a week, saves them time and allows them to do other things, which is important. But there's also a foundational kind of values and trust building exercise that happens when a human being from the care system sets foot in their patient's home that is just incredibly powerful. It rebalances the patient provider relationship. As a physician going into a patient's home, I wait for them. I see them on their own terms. I am humbled in their presence, which is really important when I think that this is a person I want to call me instead of going to the emergency room when they're feeling sick. They need to trust me. And you don't trust somebody who you don't feel like you can relate to, who you don't feel like is there for you and who doesn't listen to you. And so being able to just establish that foundation is so powerful. What we found is that if you layer telehealth on top of that trusted relationship, you unlock a ton of potential for the ease of 24/7 access and for the ability to operationally kind of scale this type of very human-centered approach. And we do that in a couple of ways. One is following a series of really in-depth, in-person conversations with members of the care team. We find that our patients are much more likely to then video in or televisit or text us or call us when they're having needs. The other thing that we think is really interesting is allowing a different member of the care team. We've talked about interdisciplinary teams. Bob Master talked about this earlier, but really thinking about the power of non-clinically licensed individuals on the care team. So at City Block, we use community health partners. These are folks who are not clinically licensed. They're hired from the communities that we serve. They are hired for empathy and for listening skills and for trust building. And they go into a patient's home and saying, hey, it sounds like that wound on your leg isn't looking so great. What if we just video the doctor in right now together? They're facilitating that interaction that allows the doc to be more efficient with their time, but still has that human contact, and using those individuals and the trust that they build with our patients and our community members as a bridge to the healthcare system is also incredibly powerful. So I agree. I think technology has to be part of the solution, but it does not function, particularly in this population, absent really solid, trusted human relationships.
So we have another question that's come by email. Has the Affordable Care Act helped people with serious illness? If so, in what ways? And are there policy changes happening now or threats to the ACA that could be important in changing those improvements, if they exist?
We can't answer that because no one's been tracking this group of people. Obviously, we covered a lot of people with insurance and the benefits went up. What's staggering here, the people we're interviewing are post-ACA. Good news, you have no problems. So they have the post-ACA benefits. And I'm looking at this and saying, wow, what could have been before? So the answer is whatever we have done has really protected people without insurance. But this crowd of very seriously ill people with insurance are not being protected. You can't have these scale of bills for that. And what happens for that. But coming out of the world of competition, and I love competition, but this idea, choose what you need, is a very dangerous assumption coming out of this, because you just don't know what it's going to work out. And I think if post-ACA, the fact that so many people, I have a drug benefit, it's protecting me, are paying $50,000 a year. So we didn't do a particularly good job of guaranteeing that prescription that you think your physician absolutely has to have is in your drug benefit. But this could be fixed. But we have not followed this group of people. What we mostly just follow is general public. They are better off, particularly if you got insurance coverage.
But ACA coverage has out-of-pocket maximums, right? So people who are facing $50,000 in drug coverage are probably in Medicare, right? I guess they have a catastrophic benefit too.
The answer is half our people said they had to pay it themselves. So what is necessary, and that's why I don't think individuals should have to do this, is to get a sample of people and go through their bills, and where I've been told I've been guaranteed by the federal government, and I'm paying thousands of dollars out for this. So what we think we guaranteed, if you look at these people's experiences, doesn't actually work out that way. But we can't answer it now because actually we didn't think the problem would be that severe. We didn't go up and say, can you describe each bucket of bills that you have? But somehow this catastrophic feature is not protecting these people, or they wouldn't have those substantial bills.
One thing, though, to mention is the sort of 65 and under group who are not Medicare eligible now have protection against pre-existing conditions. That was a big problem in the health insurance market prior to the ACA. That problem has...
Will you just explain what that is?
Sorry, yeah. So it used to be, it may still be under some of the ACA non-compliant health plans, that you can have insurance and the insurer can decide that because you have a pre-existing condition, and that could be a lot of different things, and certainly these folks are going to have pre-existing conditions by the insurance definition, they could either refuse to renew your insurance, or they could raise the price to the point where you couldn't afford the premium, or raise the deductible, or use other financial machinations. And so the reversal in the uninsured rate that brought about by the ACA is in big part because people who couldn't get insurance in the prior pre-ACA world now can get insurance coverage. They still have problems, but certainly they're not just sort of abandoned on the street, uninsured, using public facilities if they do that.
Yeah, just that I think the ACA has been an unmitigated blessing, but and it has a long way to go. So let's accept that this was. But if we turn and to add to what you were talking about with people with pre-existing conditions, in the ACA there was a provision for the Center for Medicare and Medicaid Innovation. and substantially funded. And a good example of the kind of innovations were really very, very relevant to the populations that we're talking about. And that example is, among others, was Mount Sinai Hospital that looked at its frail elder Medicare beneficiaries that were identified as what we call in healthcare frequent flyers, back and forth, back and forth, back and forth to the hospital because the system just wasn't organized for their care. And in fact, many of the issues of hospital care made things worse in terms of drug-resistant organisms and the like, and transitions to skilled nursing facilities. And so the idea of could we take a pre-identified population with complex chronic illness, low thresholds to these hospitalizations, and think about a different path for them. And it started out a different path through the emergency room and maybe an infirmary bed. But where it evolved in the second iteration in 2014, and this is just one example, is maybe we don't need to hospitalize them at all if we can put all the components of hospital care at home for this frail elder and think about what that does to the transitions and all of the risks around transitions. And that, again, is the kind of thing that did not happen systematically prior to the ACA. The benefits will not accrue on any scale, maybe for another 5 to 8 years, but I am predicting a Medicare bundled payment for a hospital at home, DRG than the hospital, and then is paid a hospital today, and the potential transfer of substantial numbers of patients that are on our medical floors today to home-based care in a handful of years.
I wouldn't say much more except to echo that I think in the spirit of Bob's comment, a ton of innovation has occurred, sort of catalyzed by CMMI and by the duals demonstrations, the demonstrations that allowed for integration of Medicare and Medicaid plans for people who are dually eligible. Those have both, I think, informed and shaped an emerging generation, I think, of leaders within kind of healthcare transformation. I would consider myself one of those, as well as starting to contribute to our published literature on what works for taking care of populations with complex needs. Even a lexicon around who those folks are, how you identify them, and then what types of care, including hospital at home, including community paramedicine models, including complex care management, interdisciplinary care teams, all of the principles that we bring to the work that we do have had a chance to be baked and germinated through an innovation process. And it is a remarkable moment in time when we can say collectively as a community, we have a problem, and this problem is both access and the quality of care that we provide to people who really need it. And we're going to try to throw a whole bunch of things at the wall, see what sticks. And this is the point in which we're really asking, well, how do we scale what we know works now? It's a very different point in time than where we were even 7 or 8 years ago when we didn't really know what worked. We know what works now. And and folks like myself and others across the country are saying, all right, well, how do we put this on steroids so we can scale it to all the people who need it? Very different problem, but it comes very much out of the legacy of so much of the work that has been done at places like Commonwealth Care Alliance and others.
I think we have time for one more audience question if someone has a good one. Oh, sorry. I've made the pressure too high. Right here.
Hello, thank you so much. My name is Ravin Bachchan. I'm a master's in public health student, and I'm also a medical student at home. And sometimes it feels like these conversations are often in the public health world, but not often brought to the academic medical world. So I was just wondering what you see as the role of academic health centers in training our future physicians to have these sort of values, whether it's the education on how to have these conversations with your patients or shifting the norm of bringing primary care to the homes, and how we can hold academic medicine centers accountable for assisting in these goals.
What a great last question.
That's a very wonderful question. So
and I want to just flag, as you guys think about your answers, the thing that Toyin said early on about how clinicians often don't ask their patients about the financial aspects of their care in addition to the clinical aspects of their care.
So having practiced and taught in a local academic medical center for many years, primary care, I have to confess that as I was doing my research, going out into the field, looking at other primary care practices, I discovered that academic medical centers are often the least interested in change. They've been the slowest to pick up some of these challenges. That's not I'm saying it sort of in a blanket way, it's not entirely true. But I've started to see that change. The Association of Academic Medical Colleges has taken on the innovation agenda as something they want to teach. And I think the piece that's always been missing is the desire to do interdisciplinary training and the need to design interdisciplinary training so that the teams learn how to function, especially for patients like this.
Just very quickly, one of my mentors when I was younger, Jack Geiger, had this saying, trying to teach the principles of personalized coordinated primary care in an academic medical center is like trying to teach the principles of forestry in a lumberyard. And now that was back then, and it's come away. But I think I have to say I don't think that's the place we're going to see these kind of changes.
Yeah, I'm going to have to double down on that one. I think we need a radical overhaul of what we believe our role is as physicians, and the voice that we give to patients, and how we interact with other members of the care team, how we value them and how we interact with them. That I think is really hard to teach in the proverbial ivory tower, where academic medicine continues to be such a hierarchy and continues to privilege research and specialization over what I believe in as the kind of foundation of good primary care, which is humility and partnership with community members and patients and their advocates, and a willingness to not have all the answers, and understanding that you can't fix everything, and the patience to walk with people on their path to better health. I think it is still it's still the case that folks who enter those types of institutions looking for that type of an experience often find their way out of the academic medical center, and I actually think that the folks who are going to force this to come to a head in the big sort of bastions of academic medical education are, I hope, going to be patients and consumers who say, I want something different for my healthcare system. I want to be able to get the very best of new technology in cancer care, and also to be made to feel truly human and in every aspect of my life in the healthcare that I interact with. I want my specialist, who is a world-renowned X or Y, to talk to my primary care doctor who knows what really matters to me. And I'm going to force that to happen through advocacy and through policy, but largely through, I hope, patients sort of voting with their feet about where they go and what they privilege and what they value in those relationships.
So we're going to end with a sort of lightning round where I'm going to ask each of our panelists to tell us like a short sort of takeaway, lesson, solution, something that you think emerges from this conversation that you want to keep thinking about and you want our audience to keep thinking about. And Bob, can I start with you?
Yeah, I'm simple. We need a independent rating of policies, which basically gives you a star and says if something terrible happens to you, it'll cover it. I have very little use for this physician information. The average physician time is 15 minutes with a patient. There are 50 different policies out there. The doctor who's trying to figure out what you should do is not going to decide if Aetna 5 or Blue Cross 4 is right for you. But we need a certification. Secondly, I got to defend people who are at home. We're sending everybody home, and the people who are answering us have the thrill of their home care new system being their daughter, their spouse, their brother, etc. If we're going to send these people home, we better have Bob's system, because we have people who have to cut back their lives because mom is coming home. Why do I talk about this? We're about to have the largest population ever in U.S. history, over age 65. If you have a parent, good news. In our study, you're about to become a primary caregiver. And so unless we can put Bob's type system in here, we are not going to be protecting a lot of people as we send them home. They need X hours of time. So we need something that protects those family members, and we need a certification on an insurance policy. And that is a public responsibility. I don't care if it's a local fire department. But somebody has to put a stamp on it and say, don't worry about the 54 pages. It'll protect you if you buy this policy.
And mine will be very short. If you want innovations, and you're not finding them in your local academic medical center or wherever else you're practicing, bettercareplaybook.org is the Six Foundation website where we're collecting these evidence-based innovations. Community health workers with telemedicine, CCA I believe is in there, but there are a lot of models of care growing up outside of our sort of traditional academic centers that are available to people.
So, and very, very quickly, you know, through the decades of my career, most or all of the innovation tried to occur on the insurance side. Case management, demand management, disease management, all failures. I don't know how much money was spent on all of that. The name of the game is care system redesign, and it's a values redesign. And Toyin really speaks to it unbelievably eloquently. In fact, it's such a pleasure to hear her. And I actually see the future of spreading Toyin, force multiplying Toyin across the country.
All right, Toyin, take us out.
I think speaking to aspiring clinicians, health system leaders, or people who are in that role, I think the name of the game for me is just ask patients, how much is this going to cost you in every aspect of the word cost: time, self-esteem, social relationships, dollar bills. We have to systemize asking, because what we find here is that if we don't ask, we can't mitigate and we can't intervene. And then that person who shows up, who's not taking their medications, who gets labeled as non-compliant, is struggling with poverty. And we can address that. We just need to ask.
I want to thank our audience and also thank our great panel and all the people who wrote in with questions. This has been really great. I've learned some things. I hope you all have too. Take care.
Thank you.